Okay, now it's my pleasure to start session 1, Transforming Clinical Practices and Enhancing Patient Outcomes by ZEISS Workflows. Please join me to welcome all the experts to the stage. Associate Professor Adrian, Associate Professor Manchima Makornwattana, Professor Cho, Professor Yi-Hun, Associate Professor Anna Khan, Associate Professor Harvey, Associate Professor Smita AGARWAL, and Professor Reinstein. Please welcome them to the stage. Now I will pass the floor to the chair now.
Good morning, everyone, and thank you very much for this very warm introduction. Firstly, it's wonderful for us to be here in Seoul with so many of our good friends and colleagues from the region. And I think, as Manoj has already alluded to, this is a growing meeting. But why is it so important for this to be growing? It tells us that the interest is really quite magnificent. And I think you've appropriately chosen Horizon as the name of this meeting. We are really looking beyond the horizon today. And sharing the stage with me this morning, first I'd like to welcome my co-chairs, Dr. Manchima, Dr. Cho, and Dr. Yi-Hun, who will help me in moderating this session. Let's begin straight away with our first speaker, Professor Anna Tan from Singapore. She will speak on the optimization of clinic workflows to meet the demands of a rapidly aging population, and this is certainly relevant for us here in the Asia Pacific zone. Welcome, Anna.
Thank you so much. I'm so happy to be here, and being the first speaker is a really great honor. Thank you for the ZEISS team for inviting me. And today I really want to talk to you about the optimization of clinic workflows to meet the demands of a rapidly aging population. So these are the disclaimers and my financial disclosures. And my other disclaimer here is that I'm a retina doctor and I'm severely underrepresented amongst all these refractive surgery people today. So I hope you give me some time in case I give you a bit of a retina spin to this talk today. Anyways, we all know that the silver tsunami is hitting Asia. And especially for countries like Japan, South Korea, Thailand, China, Singapore, we know that about more than 30% of East Asians and Singapore populations will be Asian. And when we grow older, of course, more people need eye care. And you can see that 253 million people are visually impaired globally, and 81% of these are 50 years and older. And a lot of this is from chronic eye diseases. And chronic eye diseases are very much age-related, and the big ones like glaucoma, glaucoma, macular degeneration, as well as diabetic retinopathy and retinal detachment, you can see, and cataracts, of course, which are reversible, cause a major burden on our society. You can see the prevalence goes up when you age, and not only the prevalence, but the disability-adjusted life years really put significant burdens in society. When you look at the WHO definitions of people-centered eye care, you can see there's different aspects of people-centered eye care. So one of them is empowering engaging people, strengthening government's accountability, and reorientating the model of care coordinating services. And a very interesting health care survey which was done very recently showed us that people's attitudes to healthcare is changing. It's no longer a passive experience. People are willing to pay a lot more. They want a single touch point, and often this is not in a hospital setting, but more in a community setting where it is more accessible for them. They want AI and digital technology to help them curate new models of care. And so these people-centered care workflows are aligned with the patient's expectations. And luckily for ZEISS, they don't look like in the future they're going out of business anytime soon. The predicted market for eye care devices is about 34.2 million in the US alone, and obviously globally these trends will continue to rise. And you can even see within my own hospital, the Singapore National Eye Centre, even my retina imaging workload, this is only for retina by the way, not even for the glaucoma service, you can see it's exponentially getting bigger, and over the last 10 years it has doubled. And similarly, and this is just, I just gave you the retina trend, but it goes holds for all trends. To get better outcomes for our patients, we are more and more reliant on imaging. Be it in refractive surgery, be it in glaucoma. As our treatment capacity goes up and the modalities of treatment increase, we will also see that our imaging load and our imaging needs will increase. And this is a growing trend, especially in intravitreal injections, for example, what I do, and you can see the workload for imaging really going up. And the really interesting thing is when you go and look at a patient's preference, and these are 3 articles that I went to go and look up, and they tell you an optimized time that a patient is willing to wait for their appointment. It's usually about 30 to 45 minutes, but you can see on the right, this is my visit guide in my hospital. I tell them it takes about 3 hours for my appointment. So hence there's still a lot of gaps which we need to fill because our workflow is not as optimized as it should be. And these are some considerations on how to cope with immense increasing imaging load. Obviously, we need manpower with skilled technicians, optometrists, and many ophthalmologists increasingly in some practices are also proficient at image acquisition. Space available and the number and types of machines. I often get asked this question whether a single multimodal platform is preferable or a specialized machines that do different multimodal imaging. And these are some of the comparisons when you look at whether a single multimodal platform is more suitable or specialized machines. Firstly, if you have a single multimodal platform, for smaller practices that might be more practical, you don't need to move the patient. You can view in one imaging system all the multimodalities. You know, you only have to depend on a single vendor, but of course if it breaks down or there's some issues, then you can't really get it fixed. The other thing that you can see is in specialized machines, if you have a very busy practice, you can do simultaneous imaging, and this is extremely important. For example, if I use one of my OCT machines for fluorescein and geography, this stops the workflow for me for a lot, and that's why we need multiple machines that do different things. And also, the downside is, of course, the patients may have to move from one machine to the next, and when you have different brands of different machines, you have to often use different viewing platforms, and they are not all well integrated. And individual machines also will be more costly, and also you do need to coordinate the vendors and the support. And I mean, it all comes down to different practices requiring having different needs versus a single, practice which is less busy, a more boutique practice versus the practice on the right, which is mine. You can see my imaging room is flush with machines from one end to the other, and this is only half of all the machines that we have. But it should be purposely designed to optimize patient flow. And we must keep in mind that imaging is only one piece of the puzzle. The patient's journey really comes from all the way when they arrive into the hospital, from their registration, all the way from when they get their acuity done, their vision done, they're seen by the doctor, they go to the pharmacy, and then they leave. And in all these different areas, we have different models of care that can address many of these limitations. You can see that my next part of my presentation is a little bit of something that I have put together. It's not Christmas, I know it's June, but I put together a wish list on how we can optimize imaging workflow. I split it up into hardware and software, and I realized that some of these sort of suggestions may already exist. However, I think there's still work to do in optimizing them in terms of implementation. Let's go through some of them. So in terms of, let's say, hardware design, obviously, a lot of times we face the materials. It needs to be durable materials with a user-friendly design. And also, we need to think about inclusive designs now. Like you see this example here. A lot of machines now, obviously, we cater for wheelchair patients, but a lot of it in practice may not be so practical than when we actually use it for patients. And with the aged population with multiple comorbidities, this is something we need to always keep in mind about the design. Obviously, there's a lot of move towards self-operated portable home monitoring imaging devices with AI, and this, as you can see, the Towers is one of the OCT home monitoring systems that we can do. And also, we want to be increasingly less reliant on this skilled manpower we need for taking imaging, and hence, self-operated or robot-operated automated imaging is of the future. The other thing we also want to look at, and I think my wish list for where imaging companies will go to, is also, of course, increasing technical specifications and functions. The automated registration exists, but because of a lot of systems that are protected and a lot of different systems that exist, it doesn't always happen. And even in the Eye Center today, we try our best, but a lot of the processes are still manual that can be actually sped up. Of course, when the machines get faster, we can see from the 5,000 to the 6,000 to the Plex Elite, we get faster and faster machines, higher resolution, increased field of view, and these are all great, exciting things that help our imaging capabilities become even better. Of course, the faster the machine, also it reduces artifacts. And also, one of the things that we face a lot now, because we want to have big data and databases of images, we also aren't really able to bulk de-identify at the moment, and we do a lot of them on a case-to-case basis, which is very manpower and time-consuming. And also, our batch storage solutions, and increasingly when we get beautiful images like the Plex Elite at the bottom, it's about 1 gig per image, so you can imagine how fast our databases get filled up, and why we need to invest in looking at more compression software where we can store images properly. The software viewing platforms are also really important. I think in general, the glaucoma workplace is a very well-used system by all the glaucoma specialists. I'm not a glaucoma specialist, but I think it really gives you this centralized platform with a user-friendly interface to look at progression. It can integrate both structure and function, and it has quantifiable analysis that you can look at its graphs out there for you in a very user-friendly dashboard. And I think this is a really good example of where we need to move to. For the Retina workplace, I just want to play you a video of what I use it for. We aren't as optimized, I must say, as the glaucoma workplace, and there's still some work to do. You can see that one good thing about the Retina workplace here, it allows you to superimpose 2 different imaging modalities, and this one is an OCTA and a color fundus photo that's a wide field. It allows you to be able to correlate what you see on the OCTA to the color photos, and also it allows you to zoom in and out to look at your field of view. So these are very exciting things when you look at multimodal imaging and its needs, and you can see that this helps you to utilize it. However, one thing that it doesn't help is that currently it's not so brand friendly. So if you have imaging from other machines that are maybe of a different brand, you can't do the same capabilities. And this is something which I think we should try to standardize when we talk about standardize in the future, at least some of the formats and some of the viewing platforms, so that we are able to really look at all our multimodal imaging, brand, non-brand specific, all together. The other thing also I think that we need to move towards is actually incorporating the clinical management, and this is linking imaging with electronic medical records, so that we not just keep a look at the progression of the imaging through time, but we also look at it in response to treatment. Makornwattana is a smaller company that has started doing this in a very interesting way. You can see the OCT images at the bottom are quantifiable, so they can quantify fluid, where it looks at intraretinal fluid, subretinal fluid, and sub-RPE fluid, and they can then give you a graph of the fluid change. In addition, they give you the injection time intervals, and you can see that you are really able to make interesting observations about fluid change over time, and also visual acuity is added on there. And And this is a really sort of a user-friendly dashboard, I would say, to help clinicians make decisions, and probably for a lot of the other workflows that we think about in other specialties, these are some examples that we can bring through. And I want to bring your attention also to the bottom right picture. And this is an interesting thing. It's a decision tree that sort of lets you click a few boxes, and then you can justify why you made a clinical decision. And this is very important because sometimes, especially managing chronic diseases, even though you perceive that you follow a certain regimen, you may not do that in global practice. And when you have a decision tree that records the reasons why you make a certain decision, you can then go back and not only audit yourself and your own decision making over the previous time, but you can also look at the decision making differences between different clinicians within the department, and also look at how people follow sort of treatment protocols and not. And I think this is really the exciting thing, is now we can use imaging and imaging modalities integrated with the EMR to collect real-world outcomes that we can analyze and help us to really advise our practice and make our practice more personalized and better. And the other thing I want to say is also, with a lot of the algorithms that are coming up, now we can even be able to predict the future much more easily. Just with a single scan, you can see this article is from China. Just from a single scan and segmentation, and from the characteristics that they put through a machine learning system, you can identify who is on the top a poor responder, and at the bottom is a good responder. And these are very exciting things to influence our clinical decisions in terms of how often we see the patients, as well as how much treatment they require over time. I want to leave you with the last case example, and like I said, my caveat at the beginning, as a retina doctor, so I have to talk about some retina things. But geographic atrophy is a really exciting space in retina at the moment. You know, we have therapeutics now, which we never did before. But even more so, not just the therapeutics that are coming up for geographic atrophy, it is even more so that the imaging catches up to what we need to treat people with geographic atrophy. And I'll use this as an example. You can see here for geographic atrophy, in case, I'll just give some basics. It does go from intermediate AMD to late AMD, and from the soft drusen, it sort of dissolves and becomes geographic atrophy, and that's when people lose vision. And in order for us to diagnose it, increasingly we know that multimodal imaging is important, everything from color fundus photo, fundus autofluorescence, and OCT. You see this treatment for GA, we are in very early stages of this treatment for GA. In a way, we sort of have become closer to the glaucoma doctors, where we can't tell our patients that they're going to get better. We can just tell them they'll get worse slower. So the conversation for monthly injections in the eye is that, unlike you can see the graphs, if you don't do any injections, you have that amount of progression, which is the top dotted line. If you do the injections, it reduces by 22%. And these are monthly or 2 months for one injection. So you can imagine the conversation for each patient is very difficult to make them go into a treatment that actually doesn't make them feel any better, but you have to tell them it stops them from going worse faster. So you can see that firstly, we need to choose the patients we treat properly. And this involves us finding which patients are quick progressors and progress quickly, so that these are the suitable patients to treat. And you can see we do this by looking at patterns on autofluorescence, and the faster progressors will benefit from this geographic atrophy treatment. So firstly, we need good imaging to find the patients that we need to treat. Secondly, as I mentioned, we need to show the patients the benefit of the treatment. And this is not because their vision improves or their function improves, this is because they progress slower. So for each of these patients, we need to plot them the same curve that they had, that you saw just now that was plotted for the cohort. And we do this by having to quantify the area of geographic atrophy. And can you imagine, you can see that top left picture over there. It's not easy to quantify this area all the time. I mean, there's like areas that are patchy. So we need good quantitative measurements to be able to get a good picture of the area change over time. Also, at the bottom, you can see that microperimetry increase, so we need to correlate it with function in order for them to show that, this is making a difference for the patients. And really, this is where the AI predictive algorithms come in, so that we can plot supposed natural progression and we compare it to the current progression of the patient. And this is where we need these imaging dashboards, these beautiful graphs to try and show patients, that this treatment is actually necessary. So I think this is where I feel an area where the imaging technology is crucial for us to track our treatment response and give the patient education. So in summary, we know our imaging load will continue to increase. We need to improve patient-centered care, and the overall clinic experience is key to patient satisfaction and efficient services. Many challenges in workflow can be improved with digital technology, and the advances will allow more accurate imaging and improve clinical care. We need common platforms, and we need to actually improve what we can do in terms of patient education, and advanced imaging and hardware should focus on AI integration and new models of care beyond the hospital. With that, I thank you very much for your time, and I'll take any questions.
Thank you, Anna, for the very clear picture for our busy business in the future, and also because of the aging change, we're going to have lots of things that happen in the future. So let me move on to the next session, which will talk about the accuracy, efficacy, and confidence with ZEISS Retina Workplace. Please welcome Dr. Harvey.
Morning, everyone. I'd like to thank ZEISS for the opportunity to come here and present at this impactful meeting. Okay, so these are my disclosures. And this morning we'll be talking about accuracy, efficiency, and confidence using the ZEISS Retina Workplace. And somewhere along this lecture, I think we'll also show an example of what Maximilian said, that standardization can lead to personalized medicine. So we'll talk about multimodal imaging, patient education, clinic efficiency, and how the Retina Workplace allows us to achieve all of these. First, an introduction. I practice in the Philippines. We're a multi-specialty group practice with our own ambulatory surgical center, 3 satellite clinics, and we have doctors who treat everything from the front to the back of the eye. But regardless of what your subspecialty is, all of us depend on imaging to help us diagnose patients, plan and prognosticate treatments, monitor our patient response to treatments, and with all the images, as Anna mentioned, that we have to review every day, we are in great need of image management software that allows both rapid and accurate review of images and allows us to enhance patient education. And we can achieve these two, have accurate measurements and educate patients. We can improve treatment compliance, get better outcomes, and increase our conversion rates. So I think these are the 3 main features of an image management software. It has to be accurate, it has to be efficient, and it has to give both physician and the patient that confidence that we are on the right track. Let's talk first about accuracy. So as Anna mentioned, with the Retina Workplace, we're able to input a lot of kinds of images from different devices, the OCT angiography, dye-based angiography. All of these can be seen on one single platform. And the advantage of this is that you're able to be efficient. You don't have to look at different websites or platforms with each patient. Not only this, the Retina Workplace allows you to view all that data over time. So you can see the temporal change. And lastly, you're able to actually correlate treatment with outcomes. So if you do this consistently, you input the treatment, you consistently measure the patient, you're able to standardize this, then you'll be able to personalize treatment, as I'll show you. So we're also able to visualize different data formats. It may be the numerical format for those obsessive patients who like to see the numbers, or you can do a graphic analysis, as you see below. Those lines indicate how the patient's clinical parameters are doing, and this is more easy to understand for many patients. The Retina Workplace also allows us to perform highly accurate measurements of the patient's condition. Example, in this patient who we're trying to convince to have macular hole surgery, but over time we can demonstrate to him that his macular hole is actually enlarging associated with his decrease in vision. And if we can demonstrate this, educate the patient, they will now agree to undergo the surgery. This patient was reluctant to have injections, but after our first injection, we can use the Retina Workplace to demonstrate a decrease in the area of the patient's pathology. And when they see this, even if their vision hasn't improved in one injection, they're more likely to agree to undergo subsequent treatments. A very powerful tool that we also observe is that you're able to overlay images from your fundus camera into your OCT and OCT angiography images. So now you can put together all of these images, and this helps you localize and identify the nature of a lesion. And when you're able to do this, you can do more functions. Example, now we oftentimes do our photodynamic therapy without having to do a dye-based angiography, which also has its risks. So here we can see the lesion, measure the greatest linear diameter, figure out the treatment area, and apply the photodynamic treatment just based on OCT and the overlay images. We can also observe and analyze OCT angiography images with the Retina Workplace, and from this we can do unfast analysis and visualize the pathology at different levels of the retina and choroid, and sometimes this helps us decide what's going on and plan the treatment. The Retina Workplace is also very useful for patient education, and we've learned that the patient experience greatly impacts the conversion rates, so we've set up our clinics to be very comfortable. And when a patient gets to sit in that exam chair after the tests are done, you can see that in front of you there's a screen, and the nurses are trained to already bring up the images of the Retina Workplace, and the patient can see these images, and you can discuss with the patients in real time and demonstrate their pathology to them. And then with this, we can now discuss what to do next. So we find that we're spending, ideally we should spend more and more time with patient education, and actually less and less time with examining the patients, because we have machines and technicians to help us do that. So probably right now we spend 10% of our time examining patients and 90% sitting down and educating the patients as to what they have and what are their various options. And I think the patients appreciate this because you're able to address their concerns and beliefs, and you're able to make them more satisfied and agree to have treatments. So an example would be this is a 75-year-old female with diabetic macular edema, but she also has a significant cataract, and we showed her this before the surgery, and we told her after the surgery her macular edema would likely get worse, but because her vision was so bad from the cataract, we went ahead, removed the cataract, and next day she's very happy with her vision, but 3 weeks later the macular edema has worsened, and that we can show this in real time to the patient that their retina has thickened. There's this big swollen area, and we convinced this patient to try one injection first. This is a patient very afraid of having injections, but on the next visit we showed her that the retinal edema has decreased, that yellow line has decreased, and she can feel improvement in her vision, so she agreed to continue with the injections. And of course, we like to try to lessen the treatment burden for the patient. And you can see here towards this visit, her vision was 20/20. There wasn't much edema, and we told the patient on your OCT, we can actually see these cystic spaces, and we can measure out in front of her that it's 410 micrometers. And we said, we recommend that you have an injection at this point, even though your vision is good. But the patient wants to observe, and when she comes back in the next visit, you can see that, the size of that retinal fluid has increased, even though her vision is still 20/20. But because the patient can see this, because they've been educated that the amount of edema correlates with their vision, she decided to have the injection even though her vision was still good. So if you can have a standardized process where when the patient comes into your clinic, your technicians will do the tests such as OCT tests, and your nurses can input the treatment that you did on that day, you now have a very powerful tool for personalized medicine. So as you can see from this patient, at the start, this patient received frequent injections of anti-VEGF drugs, and this patient knows we're trying to lessen her treatment burden. So over time, we actually increased the interval between the injections, and we actually got her to stay quiet for a long time in this period. Okay, but one day I walk into the room and she's looking at the chart and she tells me, "Oh look, doctor, that yellow line has come up. I think I need an injection. Can I get it today?" Okay, so it's just like a 1-minute consultation, because the patient has now been educated and they know what's happening to them and they know what's best for them. So does this technology translate the results? So a few years ago we did a study. We had clinics that were not yet fully equipped, and we compared the conversion rates among the different clinics, and we found that we had the highest conversion rates in a clinic where we had all the machines, the forum, and the workplace available. So when we tell these patients you need this treatment and you have all these images in front of you, there's a very high likelihood they would agree to have the treatment. Whereas we had a clinic in a place where we didn't have these facilities, we had to send out the patient to get the test done, and many times the patient would not come back or might not agree to have the test done. So having more equipment may cost you more, but it also increases your conversion rate and ultimately generates more revenues and allows you to do what's best for the patients. So let's now talk about the Retina workplace and how it improves your efficiency and confidence. So we did this little study to determine how efficient and how physician confidence is improved by the Retina workplace. This is called the CRISP study. And the methods were simple. We got 30 sets of print images or analog images with the treatments indicated for each image. We arranged them chronologically. And on the last image, we asked the retinal specialist, would you treat or not treat? So we had print images, and then we had the patient, the doctors looked at the digital workflow images using the macular thickness program, and we asked the same question at the end. And these doctors, they had access to the graphical analysis and the treatments that's done and the patient responses. So these were 10 retinal physicians that we recruited, and half of them looked at print images first, followed by digital and vice versa. And these were our main treatment parameters. And what did we find? We found that using the digital workflow, we greatly cut down the review time by about half. We also found that whether the doctors looked at the print images or the digital images, the inter-rater agreement rates were not significant. But within a retinal physician, there was 71% intra-rater treatment physician agreement rate. So there was actually a difference for each physician, whether he looked at the digital or the analog images. We surveyed also the physicians, and we found that they were much more confident if they looked at the digital images. So these are just a couple of examples. On the left, you see the print image. On the right, the digital image. The review time for this patient with about 6 visits was about the same, but the treatment decision was different. This is the same doctor, but looking at the digital workflow, his decision was different because now, down here, he could see the pattern of the previous treatments, and he realized that maybe it's not the time for the next shot. This is another patient, more complex, more visits, and when there are more visits, we find that the digital workflow is more useful in decreasing your review time. And here, both in the print and the digital workflow, the decision was the same, but there was a higher confidence level when you look at the digital workflow, because now you can see how the patient was responding to his treatment. So ease of use was definitely better for the digital workflow. Imaging has now become an essential part of the retina clinical practice. We have to use these multimodal images to help us arrive at a more accurate assessment of the patient's condition and whether they're responding to treatments. In many practices, doctors are still using print images. That this makes it very inefficient and it increases the patient waiting period. So we find that adopting a digital workflow makes life a lot easier. These digital workflows reduce the review time, give patients and doctors more confidence. It's significantly easier to use than the printed images. Your printer doesn't, if your printer breaks down, then you don't have analog images to review. And in this study, the time savings is slightly underestimated because we didn't account for things like having to print it out and then collect these images and transmit them to the doctor. So why were there differences in the treatment decision agreement rates? Because when you look at the digital workflow, you can see that you can easily identify what's the dosing strategy that you follow. Whereas if you look at the print workflow, it's not so obvious. So I think this leads to a difference in your intra-radios decision making. So the Retina Workplace provides an accurate assessment of disease status, response to treatment. This allows you to personalize the treatment to your patients. It facilitates patient discussion and improves conversion rates. You can certainly improve your review time. It raises both the confidence of patients and physicians that you're on the right track, and there's generally good interoperability. I'd like to thank our co-workers in this study and invite them all to come to Manila for the APPRS 2025. See you soon. Thank you.
Thank you very much, Harvey.
So my topic today is streamlining multi-location management with digital solutions. So I would like to start by saying, politely disagree with Mr. Foerst that digitalization is not the future, but the present. I think ZEISS is working hard, but I think we can do a little bit better. So I've got 3 practices in one upper south of Sydney, which are stretching across 100 kilometers. And first practice was set up in Nara, which is about 80 kilometers away. And second was, it's about 30 minutes drive. And then last one was set up only recently, which is customized practice in Wollongong. And it is, the 3 practices stretch approximately 100 kilometers apart. And it takes about 60 minutes for me to drive. And the patients will also need that time to drive if they have to come to see any of the doctors or any of the locations. It's at the most beautiful part of Australia, surrounded by sea and mountains. So taking you guys to the past, when I had all these practices without digitalization, we had heavy paper files with printed intraocular lens master pages, about 6 to 10, depending on what the patient wants, and OCT printouts, theater lists with possibility of course, transcription errors between measurement, planning, and actually doing the surgery. Nurse we selecting the lenses, then typing the list, nurses preparing the list, ordering the lenses, warehouse shipping. Only to get disappointed on the day of the theater surgery that the wrong lens has been ordered. Or we have to open multiple windows to talk to patients when we connected and we didn't have the forum. There was lack of simplistic visuals to educate patients. So now with forum, what I've done is, with the 3 practices across 100 kilometers now, I have got forum which connects all 3 practices. So what it does is, it connects all the existing devices at all to 3 locations, and whichever location the doctor is working, we can see all the results whenever the patient comes. So it links data from IR master and other devices in the cataract workflow up to the Callisto eye in theater and then back to the forum in the clinic. And same with refractive workplace. So it causes seamless, transcription-free refractive and cataract workflow for me. It also standardizes times per patient. So with the EQ workplace, what I do is I sit with the patient. It's very easy to use. I open the EQ workplace cataract planning, talk to the patient what he wants, if they want myopic target, I can change. If they are post-refractive, I can use the case, whatever I want, instead of having to ask the staff to go back and print and give me another set of pile of pages. All the lenses are available, and it does not take much time for me to select the lens. I can also complete the plan and also send the results or selected lens to the reception or to the vendor to be delivered on the further day of the surgery. Avoids transcription errors. So this is how I do. I just sit in front of the forum. I've got all the images. I have connected the forum with not only OCD IR Master or Magnus Photo, but also with Pentacam, MS39. My staff do a print out a PDF image and send it to me. So I've got all the images at one forum, one platform, rather than opening multiple images. It's good for teaching as well for the patients, that's why we are selecting, why we cannot choose a multifocal lens, or why multifocal lens is suitable for them. I can discuss, I can plan, and also confirm the lens. So this is what it used to happen when I did not have EQ work or forum. Patients would have biometry, we would print the biometry, I would highlight the IOL selection. Patients would, while the patient is sitting with me, and then suddenly the patient says, no, I want to see close up better rather than distance. I go out, I ask my staff to print another IOL master, aiming for whatever target, -2, -2.5, and then I choose the lens, and then again the patient changes their mind. No, I want monovision. Again I go back, I tell the patient, the staff to print again the pages. So it used to take too much time, and then suddenly I realized the patient is post-refractive, and printout is on K, not total K. So all these things would take more time. Staff would have been seeing another patient. Rather than that, they were just listening to me and getting engaged just one patient. Then we record the lens on the theater list, on the patient's folder, theater list. These details were typed by the staff, sent to the theaters. Theaters would order the lenses. There was a lot of error with transcription. And the images would be sent on a USB, exported on a USB, which I would take to theater without the reference image, and I would put the lens in theater. Images exported to the microscope. Nurses will put the axis, depending on the nurse who's working, whether she's used to it or not, she may take up to from 1 to 5 minutes. By the time, I'm getting a lot of frustration. But with EQ Workplace, I have avoided that frustration. Biometry is done. I select the lens on EQ Workplace, complete the surgical plan, release the plan by area network, order the lens, either on the same day or it gets planned, autopopulated, sent to the theaters with the lenses all through the Callisto image, and now everything is under my control. Nurses don't have to do anything. So starting from pre-op measurements, surgical planning, and actually surgery day, everything is under my control. And I go to my theaters with everything exported on the microscope. I do not have to carry the USB with me where there is a risk of errors. So this is an example of, this was a patient who is the husband of a very big referrer, and he was going on a long cruise, So he rings me 2 weeks before his actual planned cruise date that I want to get both eyes done before I go. I said, all right, so I planned his surgery, one eye for a Thursday and the other one for a Monday. He comes on Thursday for first eye surgery, and then he says, why can't you do my other eye today? I said, yeah, I can. I need to check whether you have the lens or not, because he wanted a multifocal lens and he had a bit of astigmatism. So we had the lens available, but obviously I didn't have his planning. What I had to do, my staff rang this clinic upstairs and they released the plan. It came directly to the microscope. We did accurate alignment of this multifocal toric lens. Surgery done both eyes on the same day, patient on the cruise. This is another example. So before I had this imaging or digital solution, I wrote this lens at 78 degrees, but when I was transcribing as the lens which I wanted, I wrote accidentally 178 degrees, as you can see. So 178. And then when I go into theater, luckily my microscope has got everything, so it told me, no, it is not 178, it is 78 degrees. I could have easily put this lens wrong and blame the lens that patient hasn't got the right lens unless I dilated the patient. Now, this is an example of how we were marking for toric IOLs before. I have taken the consent, verbal consent from the patient to be in this video. So about 22% patients are undergoing cataract surgery have got astigmatism of more than 1.5 diopters. We know that the success to achieve good visual outcome and happy patients relies on accurate alignment and rotational stability, more so with multifocal toric IOLs. The most common cause of dissatisfaction is residual refractive error. We know 1 degree rotation can reduce astigmatic correction by 3.3%. Initially, many years ago, when toric IOLs came out, we all were doing our own manual marking, and then when the numbers increased, we asked our anesthetists to do the marking. And this is how the anesthetists do the marking. Please watch. The way they are doing the manual marking, the patient is moving the head, anesthetist is trying to mark at 0 and 180 degrees. Patient is closing the eyes. Instead of going from the front, he's going from the side at 0 degree axis. And we were doing surgeries based on the manual marking. I really think that toric IOLs are very forgiving, that they were still giving us good results. Why would I not use image guidance and have accuracy, precision, and good outcomes? So now I've got Cadera also in my theatre, which obviously provides chamber stability with reduced usage of phaco energy due to its quattro pump. Followability is excellent with that, and it's really beautiful. I really love it. Watch this, how beautifully the fake cataract comes. Even in the densest cataract, the chambers maintain corneas are clear. And cherry on the cake is that the lens is on the machine. And that's the last minute check for the nurses before opening and giving the lens to me to make any errors. Staff is happy, I'm happy. They can watch what is happening and they can anticipate what will happen, what instruments to give to me. With digitalization of cataract workflow, we can save up to 6 to 14 minutes per patient based on both these studies. Even I can feel with pre-op planning, with measurements, planning and surgery, saving 6 to 14 minutes, which could be about approximately 2 cataracts, 1 to 2 cataracts for many of us sitting over here. It can be realized for any type of cataract procedure, from standard cataract to astigmatic eye requiring a toric or a multifocal toric IOL. It is consistent with literature. So the fractal workplace of ZEISS, I can check the planning. I do want the ZEISS to work on this, that at the moment we are still entering the data manually. If we can have IOL master, pentagram, or whatever modalities, it can go directly into refractive workplace. It would make it much easier for us and transcription-free error, because at the moment I have to still go back and check, cross-check, but it is all connected to VisuMax. and all the data, what we do, comes back to Forum so I can check all my details. So the benefits of digital integration in my practice are many. In my practice with 3 locations, approximately 100 kilometers apart, digital integration has brought us closer by having the ability to examine patients at any location, any time, and access their reports online without having to worry that I don't have their reports and not see the patient on the day because I don't have their files. Surgical planning can be done at any location, any time, with seamless data transfer, avoidance of transcription error, integration with theater, laser suite. Staff is happy because they don't have to worry about me getting frustrated and annoyed while they are entering the data on Callisto for toric IRs, which I can do with my Lumina handpiece. Don't have to buy all the expensive machines at each location. I can get one practice with all the machines, get their testing done, and have everything exported to Forum and see the patient over there. I have got only 3 practices. I'm a very small person, but all these big companies have embraced digital solutions. Amazon has transformed retail by streamlining their operations, reducing repetitive tasks. Netflix revolutionized the entertainment industry by shifting from a physical DVD rental service to a cloud-based streaming platform. Microsoft, Nike. So, in the end, I would say digital integration is not a choice, but a necessity in today's world, not future. We have to embrace it if you want to get good results. Thank you.
Okay, well, wow, what a room. Isn't it amazing? Notice how the optics have been perfectly adjusted by ZEISS. This room would look quite empty if we weren't all sitting at tables of 9 or 12. Yeah? If we were all sitting in rows, it would be half empty. But they fixed the optics. It looks like a full audience. It's great. Anyway, so you know me, and if I go into detail about something, we're going to be here all night. So I'm going to pick just a certain aspects of the refractive surgery workflow station. Otherwise, it really is much more comprehensive than what I'm going to talk about. But I'm going to talk about actually the 2 most important elements in refractive surgery. And they are not the wavefront. They are not micro details. They are refraction and application of the refraction to the eye. And those are the biggest sources of error in refractive surgery. And you have a lot of marketing around, oh, you know, the wavefront guided, the corner wavefront guided, the this, the that. It's like, no. You're worrying about that, but you're leaving out the biggest problem, which is accuracy and nomogram adjustments and application of refraction to the eye, which is not necessarily putting the refraction directly into the laser, there's a nomogram, and not necessarily the axis that you see under the microscope. So I'm going to just concentrate on those 2 things. We all know that this IOL Master 700 has been adapted so that the infrared image is now used for cyclotorsion, not just for the Callisto, but also for the VisuMax 800. And so there's an export via DICOM into Forum. And Forum, of course, started off as a magnificent glaucoma project, which is now completely worldwide accepted as inherently obvious. We've seen it now in Retina, and I'm going to just show you some aspects of how this is going to make refractive surgery more accurate for the average surgeon who doesn't do a lot of these things externally in Excel and in separate programs. So it starts off obviously by looking at the exam and choosing the right images. Once you've chosen the right images, now you are into planning your smile procedure. Now, up here in the corner is an indication that this case has an approved infrared image for cyclotorsion control. And now we're going to enter the offset of the visual axis from the center of the pupil. And now we're talking about nomograms, because people say, oh, the machine doesn't work, it undercorrects. I hear that all the time. It's like, no, the machine works perfectly. You have a system that results in an undercorrection if you don't apply an adjustment. And so having a personalized nomogram is actually the way to improve your outcomes, make patients more happy, reduce your enhancement rate, which of course increases your referral rates. And I know in Retina your problem is too many patients. In refractive, our problem is that it's a marketing-driven specialty because it's elective and people are scared. And so, you know, having accuracy is something that enhances your practice. So, we go to patient management and we select import the patient, we search for the patient, we import the patient, and I'm going to show you what happens in between, but then you're in the OR and then it's as simple as, you know, falling off the log. You're approaching the eye, you make contact, there is a docking alignment, there is cyclotorsion automatically placed. You verify the cyclotorsion by looking at the static IOL master image and the live image, and then you start treating. It takes 16 seconds to do everything like that. Now that's because of the preparation. So where's the preparation? Well, the nomogram is normally something that, if you're a real expert, you do this in Excel, you use multivariate regression analysis. Not everybody remembers this stuff from school. So you can go to a commercial software like IBRA or something, or SurgiVision, and have your staff enter the data, produce a nomogram. It gives you an equation, you put it into Excel, you then put the refraction in, you then look at the data input, you then put that into the laser. There's multiple steps where you can have errors happen. And so therefore, an integrated solution is the maximum. So we add a new patient, we put the refraction in, and at the post-op stage, we can also add the data. Say, for example, here's the 1 month spot, you put the refraction post-op plane on -1/4 at 130, or even better, you have an EMR, and you export the EMR into a spreadsheet, which then imports all of your data straight into the visualized software. Now, how did ZEISS decide to do this? They decided to do it according to standardization. And standardization in refractive surgery is still an adolescent, particularly in the lens forum. Lens surgeons tend to ignore the standard for reporting refractive surgery. The reason for this is that reporting mean vision hides the percentage of eyes that are 20/20. And we know that refractive surgery with a laser is much more accurate than any IOL calculation can predict in advance. We have light adjustable lenses if you're willing to do 5, 6, 7 visits post-op. But essentially it would be nice to get it right the first time. And so I want to demystify the burden of doing this for yourself. When you do a treatment, you have to enter the pre-op refraction, you have to enter the target, and therefore you have the attempted correction. So these are numbers that you need to already put in the machine just to do the treatment. So why put them in twice? Well, if you put it into this refractive workplace, you've already entered it. Therefore, if you only enter one more number, one value, and that's the post-op 1 day visual acuity, and you never see the patient again, you suddenly have the cumulative vision chart. Percentage of eyes that were 20/20 or 20/16 on day 1. Well, what if you really go for it and you like make this huge effort and you put 3 more numbers in for that one eye at 3 months? Just with that, you now have all of these graphs. And so you have the attempted versus achieved, you have the accuracy, the percentage of eyes within a half, within 1, you have the magnitude of the astigmatism here, and you have the astigmatism attempted versus achieved, and you have whether there's a systematic cyclotorsional problem in your practice. And all of that is just by entering 4 numbers. It's not like climbing Everest, it's easy, okay? Now, if you want the rest of the graphs, you have to enter 2 more values, which would be the pre-op best spectacle corrected vision and the post-op best spectacle corrected vision. It's not a big effort to write down what the patient has seen post-op with his best spectacle correction, because it also tells you about the safety of your procedure. Like if you've lost 2 lines and you don't know it because the patient's 25 and happy and you didn't refract them, you wouldn't know that the patient lost 2 lines. So there's just 2 more values. And then that gives you the 8th graph. And to get the 9th graph, which is stability, which is required for publication, well, just enter 2 more values at 1 year. Or you can really go for it and have a peer-reviewed publication in the Journal of Refractive Surgery, the top-rated refractive surgery journal, by just entering the 1 month and the 12 months as well as the 3 months. So you see, people are scared of this, but it's nothing. It's literally no effort. And you can have publication standard refractive surgery outcomes like that, just a little bit of effort. So the standard graphs were applied into the visualized software. And so you instantly get this, but you get to choose, for example, which surgeon you're analyzing, the type of refractive error, you can choose which data, how long you want the follow-up, you can choose what age range, you can compare young people to old people, you can start to really look at your own data. Now, what is a nomogram? The nomogram is the difference between what you enter into the laser and what you got as a result. That's a nomogram. So as you can see, because in my clinic, our standardized protocol for refraction is to push plus and push sil, we end up undercorrecting with our laser if we just enter the data. That's because, I'm sorry to say, the average in the world, which is what the nomogram inside the laser is based on, do not push plus enough. They over-minus patients. And so I suffer from that because I do push plus. So I end up undercorrecting. And some clinics say, no, I entered the number and it's perfect. And well, then you over-minus. But keep doing it. Keep doing the same thing. Because if you're standardized, it's okay. So we have this ability to compensate for the different styles in refraction in different practices, which of course there should be different styles. Refracting for glasses is an art. Refracting for refractive surgery is a science. It's an exact number. It's not an opinion. You don't reduce the cylinder so the patient's more comfortable. You don't push the axis onto the horizontal or the 45. You don't try and symmetricize the axis by mirror symmetry. This is a number, and you want the actual number. But you see, in biology, there are outliers. And so here's an example of a case where the spherical equivalent was only slightly undercorrected. And I'm going to show you why. I'm going to go here, and I'm going to assign that point as an outlier. You don't want to put noise into your nomogram. There can be other circumstances why a case doesn't correct properly. For example, we know that in the middle of my surgery day, I live on an island called England. And on this island, the weather can change from morning to afternoon like that. So it can be sunny in the morning, and then we have torrential, hurricane-style drops this big in the afternoon. So the humidity changes. And what if that happened on that day, and one wasn't paying attention, and one undercorrects? Well, that data should not go into your nomogram, because unless that happens every day, and then you have to put in the time of the day that you operated on, and the humidity. So you see, in this case, the cylinder of that eye was absolutely undercorrected. And so I can't put that in the data, otherwise it'll pull the nomogram down unjustifiably and incorrectly. So there's a customization that's required. And once you have this nomogram, well, then you got your refraction -3, -1 at 22, but the data entry for us is -3.459, -1.134 at 22. And the surgical equivalent is about a half a diopter more. And some surgeons just say, oh yeah, it undercorrects. I just put a half a diopter of sphere more. Well, okay, but the cylinder is going to be undercorrected. So you have the ability to customize sphere and cylinder. And it's so easy to do. People are scared of it, but it's actually nothing to it. So you've got your nomogram established from your data, you export it, and now import that into the workplace planning station. And so when I now, with my nomogram inside the device, if I want to treat minus 425, minus 0.75 at 22, I enter minus 425, minus 0.75 at 22. I don't have to enter minus 5.126, minus 1.127 at 22, because the nomogram is already inside and the calculation is done for me in the background. And this reduces data entry errors. Because if you're changing the number you're treating in the laser with what you actually refracted, that's a calculation. And so having your personal nomogram, you can look at the details if you're worried, but having this personal nomogram is the way to make your results more accurate, your enhancement rates lower, your patient satisfaction quicker, and I know in Retina it's more about whether people can see better with the light on or the light off. But in refractive surgery, it is critical for us that patients see well on day one, because the referral enthusiasm drops exponentially from the time of surgery. And so if someone is super happy on day one, you will get, let's say, 10 referrals. If they're super happy at 1 week, you will get 7 referrals. If they're super happy at 1 month, you'll get 4. And if they're super happy at 3 months, maybe 1, maybe none. Because what happens on day 1 is everyone goes, how was it? How was it? How was it? It's like, it's amazing. I can see everything. Well, give me that surgeon's number. Or, how was it? It's better. It's still blurry, but it's better. Now, the coworker is not exactly saying, all right, well, let me know how it goes. Yeah, you understand? So these are simple things that you can do, which are automated, computerized, and calculated for you in the background. So that's one aspect of the refractive workflow. And I could talk about the other aspects for 15 minutes each. You don't have the time. So I concentrated on one, and I finished on time, which is very unusual for me. So thank you very much.